Well, a very good morning to all. Let's begin our first session. The session is on glaucoma management, decision making. I'm Dr. Roshni. I'm a glaucoma consultant at Chaitanya Eye Hospital, Trivandrum. I'll be speaking on medical management of glaucoma. We have Dr. Ronnie George, who is the director of glaucoma services at Shankara Netralaya, Chennai, and he's the director of research also. He will be presenting on normal tension glaucoma. Thank you, sir, for joining with us and welcome to the session. We have Dr. Manoj Prathapan, who is a professor at Amrita Institute of Medical Sciences. He will be speaking on glaucoma surgeries. Welcome, Dr. Manoj. Next will be Dr. Lita George, who will be speaking on YAG-PA in glaucoma. Slides are not coming. Yeah, fine. Okay. So let's begin the session. The medical management of glaucoma, the choice. The goals of managing patients with glaucoma are control of intraocular pressure in the target range, stable optic nerve and RNFL status, and stable visual fields. The benefit of controlling intraocular pressure has been well established in our landmark studies. According to the early manifest glaucoma trial, a 25% decrease of IOP from baseline reduced the risk of progression by 50%. As per the CNTGS, the progression rate in the treatment group was 12% compared to the control group, which was 35%. Ocular hypertension treatment study also proved that the progression to POAG was 4.4% in the treatment group and 9.5% in the control group. And OHTS also gave some predictive risk factors like increasing age, baseline high IOP, increased cup disc ratio, thin cornea, and high pattern standard deviation. OHT without additional risk factors treat when the IOP is consistently above 28 to 30 millimeters of mercury. OHT with additional risk factors follow OHTS guidelines. Minimum 20% IOP reduction is needed. In pre-perimetric glaucoma, decision to treat should be individualized based on risk assessment, RNFL assessment, and constant monitoring and follow-up is mandatory in pre-perimetric glaucoma. So concept of target IOP should be clear. It's an IOP range which is identified below which further damage is considered unlikely, and this will limit the progression to a rate that will preserve visual function without affecting quality of life, and it depends on stage of disease, baseline IOP, age, life expectancy, central corneal thickness, and rate of progression. It's a dynamic thing, and periodic revision or resetting is needed. Diurnal phasing even on treatment may be needed in some cases. A lower target IOP can be justified in severe disease, progressing visual field defects, presence of risk factors. No validated algorithm for determining target IOP currently exists, and it's highly individualized. AAO recommends a 20% reduction from baseline in mild glaucoma, 30% reduction in moderate, and 35 to 40% reduction in severe glaucoma. So coming to medical management, the prognosis and management plan and the likelihood of long-term therapy should be well explained and discussed with the patient. And the things to be considered are quality of life, comorbidities, and life expectancy. The main concerns of medical treatment are adherence to treatment and the expense of treatment and local or systemic side effects. And choice of therapy is a combined decision. Systemic comorbidities that deserve consideration include asthma, COPD, cardiac arrhythmias, and depression, and pregnant and nursing patients also deserve a special consideration. Anti-glaucoma medications are classified according to the pharmacological category. Prostaglandin analogues are the first-line therapy. They decrease the IOP by increasing the uvascular outflow. Prostamides include bimatoprost, which has a dual action of increasing the trabecular outflow as well. Other prostaglandin analogues are latanoprost, travoprost, and tafloprost, and docosanoid, which is unoprostone. All prostaglandin analogues are administered once daily, either as monotherapy or in a combination with beta blockers. The most common adverse reactions are conjunctival hyperemia, iris and eyelash pigmentation. Contraindications are cataract surgery with PC, rent, and vitreous loss, herpes simplex keratitis, either active or quiescent, uveitis, and cystoid macular edema. Prostaglandin-associated periorbitopathy syndrome is worth mentioning because we encounter that very often. Include periocular skin pigmentation, hypertrichosis, orbital fat atrophy, deep upper lid sulcus, tight orbit syndrome, and upper lid ptosis. And these are more with bimatoprost and travoprost. Tight orbit can pose a difficulty in monitoring IOP with GAT, and to reduce this side effect, we should instruct the patient for proper drop application without spillage. A partial complete reversal of these symptoms have been reported in 4 to 6 weeks after treatment discontinuation. What's new among the prostaglandin analogues? Latanoprostene bunod is a latanoprost nitric oxide donor conjugate, a novel EP3 receptor dual agonist hepatoprost is there, and selective non-prostaglandin prostanoid EP2 receptor agonist omidana-PAG, isopropyl. Coming to beta blockers, timolol 0.5% is a first-line drug, reduces the production of aqueous humor, but the low efficacy is lower with long-term use. Systemic side effects are common like bradycardia, bronchospasm, depression, hypoglycemia. Locally, dry eye can occur, contraindicated in asthma, COPD, more than first-degree heart block and cardiac failure. Cardioselective is beta-axolol, but it does not completely eliminate the cardiopulmonary side effects, but reduces it. Topical beta blockers may be used once or twice daily, but nighttime dosing is associated with limited efficacy and also can cause visual field progression because of nocturnal reduction of systemic blood pressure. Alpha agonists decrease the aqueous humor production by increasing the UV vascular outflow. Brimonidine increasing the UV vascular outflow as well as decreasing the aqueous humor production. Brimonidine 0.2% and 0.15% are commonly used. Side effects are allergic conjunctivitis, follicular conjunctivitis, somnolence, fatigue, contraindicated in MAO inhibitor therapy because it can cause hypertensive crisis. Brimonidine is absolutely contraindicated in children younger than 2 years of age. Topical carbonic anhydrase inhibitors decrease aqueous production. 1% brinzolamide and dorzolamide 2% are used. Adverse effects are corneal edema, metallic taste and conjunctivitis, contraindicated in sulfur allergy, sickle cell disease. Systemic carbonic anhydrase inhibitor is acetazolamide, commonly used 250 mg or 500 mg. Adverse effects are Stevens-Johnson syndrome, malaise, anorexia, serum electrolyte imbalance, renal calculi, paresthesia, which is very common, and abdominal cramps. Contraindicated in sulfonamide allergy, kidney stones, aplastic anemia, and sickle cell disease. Cholinergic agonist in use is pilocarpine. Adverse effects increases the trabecular outflow. Adverse effects are increased myopia, decreased vision, brow ache, and retinal tears and detachment in predisposed cases, and contraindicated in peripheral retinal breaks and is pro-inflammatory, hence not used in neovascular glaucoma and uveitic glaucoma, and also in malignant glaucoma. Rho kinase inhibitors are a newer addition. Commonly used are ripasudil and etazudil. Increases the trabecular outflow, decrease episcleral venous pressure, and decrease aqueous production. Side effects are common: conjunctival hyperemia, blepharitis, honeycomb cornea as well as cornea verticillata, and conjunctival hemorrhage and instillation site pain are also there. Currently no contraindications. Hyperosmotic agents control the acute increase in intraocular pressure. The mechanism of action being dehydration of vitreous. Mantol 20% is used IV, or oral glycerol is also used. Adverse effects are headache, congestive heart failure, renal failure, mental confusion, contraindicated in renal failure, heart failure, and potential CNS pathology. Fixed drug combinations are available mostly with timolol and prostaglandin analogues, timolol and brimonidine, timolol and carbonic anhydrase inhibitors, and even the trio timolol, brimonidine, and brinzolamide are available. So coming to anti-glaucoma medications in pregnancy, balance the risk of glaucoma progression against concerns for safety of fetus. Data on risk are limited and is not completely safe. Only brimonidine has a pregnancy category B rating. All other anti-glaucoma medications are C rated. There is a theoretical risk of premature labor with the PG analogues. Oral carbonic anhydrase inhibitors can cause teratogenicity in animals. Rho kinase inhibitors are not assigned a pregnancy category and no data exist on the use of them. Brimonidine may cause CNS depression and apnea in newborns and should not be used in late pregnancy near term. Monitor the fetus regularly for arrhythmia and bradycardia for patients using beta blockers. In lactation, timolol and dorzolamide are approved by the American Academy of Pediatrics for use during lactation and should be used with punctal occlusion to reduce the systemic absorption. But beta blockers are excreted in breast milk in concentrations several times higher than in plasma. So systemic cardiorespiratory side effects can occur in infants. PGA may be considered for use in a breastfeeding mother. And AGM in children, beta blockers are first-line agents in suitable pediatric cases with no cardiopulmonary issues. And apnea and bradycardia may occur in newborns and infants, so be careful. PGA has a similar efficacy. Both dorzolamide and brinzolamide are effective in reducing IOP in children. Systemic acetazolamide has a potent efficacy in children, especially before surgery. Chronic use may lead to failure to thrive, enuresis, lethargy, and nephrolithiasis. Brimonidine is absolutely contraindicated in children younger than 2 years of age. Best to avoid in children less than 6 years of age and less than 20 kg of weight. Cause CNS depression, apnea, because it crosses the blood-brain barrier and children has an immature blood-brain barrier. That finishes my session. Thank you. Next session will be by Dr. Lita George. She will be speaking on YAG PI in glaucoma.
A very good morning to all of you. So my topic is PI in glaucoma, when to decide. Straight away going into the indications, primary angle closure disease is the most common indication for YAG iridotomy. Then we have plateau iris, which again belongs to primary angle closure. Then acute primary angle closure, secondary angle closures with pupillary block, and the less common indications include nanophthalmos, microspirophakia, aqueous misdirection, and all generation phakic IOLs. Primary angle closure disease is the most common indication for a YAG iridotomy. Here the mechanism, there is a related pupillary block because of various anatomic and physiologic factors, and the aqueous faces a resistance for the outflow from the posterior chamber to the anterior chamber. Aqueous gets trapped behind the iris and drives the iris forward. So by using a focused laser energy onto the iris, you create a hole which allows the aqueous to flow both through the iridotomy and through the pupil, relieving the pupillary block. So primary angle closure disease is a spectrum which consists of primary angle closure suspect, where you have more than 180 degree of iridotrabecular contact, but the intraocular pressure is normal, there is no peripheral anterior synechiae, and the optic nerve head is also normal. When it comes to primary angle closure, along with the iridotrabecular contact, you get elevated intraocular pressure or peripheral anterior synechiae or both, but the optic nerve head is normal. When the optic nerve head is also affected, it becomes primary angle closure glaucoma. So regarding PI in primary angle closure disease, in primary angle closure glaucoma, there is no doubt you have to definitely do API. There is some controversy as to whether PI is going to help when there is extensive synechial angle closure, but the current dictum is even if there is extensive closure, you have to definitely do a YAG iridotomy. In primary angle closure also, you have to do a YAG iridotomy, and the dilemma is only with regard to primary angle closure suspect. So let's see the natural history of the disease. This is from the Vellore eye study, where they followed up the patients for 5 years, and they found that 22% of the primary angle closure suspect gets converted to primary angle closure, and 28.5% of primary angle closure gets converted to primary angle closure glaucoma. The hand-on eye study, they found that PACS conversion to PAC and PACG was 6%. So the Asian literature, the incidence of PAC and PACG varies from 5 to 25%. So now the key question is there any benefit for doing PI to prevent primary angle closure? So let's see what does the literature say. So this is the SAP trial, or the Hongshan Angle Closure Prevention Trial, which is a population-based study conducted in the southern province of Hongshan in China, where they screened around 12,000 people for PACS and enrolled 889 asymptomatic PACS patients, and one eye was treated with laser PI and the other eye served as control. So almost all the confounding factors were eliminated, and the outcomes measured were acute angle closure, raised intraocular pressure, and peripheral anterior synechiae. And this was the 6-year outcome of the SAP trial. Acute angle closure developed in 5 of the control eyes and 1 of the LPI treated eyes, out of which 3 controls and 1 treated eye developed acute angle closure after dilatation, that is after getting exposed to a provocating factor. Raised intraocular pressure was noted in 5 control eyes and 3 LPI treated eyes, and PAS more than 1 clocker was noted in 30 control eyes and 15 LPI treated eyes. The 14-year outcome of the SAP trial was published in 2022, where again the outcomes measured were same, and they found that a total of 33 LPI treated eyes and 105 control eyes reached the primary endpoint. And the conclusion was, despite a 2/3 decrease in PAC occurrence after LPI, the cumulative risk of progression was relatively low in a community-based PACS population over 14 years. One important point to be noted, that is, while the study was extended from 6 to 14 years, the number needed to treat to prevent an endpoint dropped from 44 to 12.35, highlighting that over long term LPI was found to be more beneficial. Then we have the ANALYSIS trial, that is the Singapore asymptomatic narrow angle laser iridotomy study, where again it was a multicentric trial. 480 asymptomatic PACS patients older than 50 years were included. One eye underwent LPI and the other eye was controlled. Outcome measures were PAC, acute angle closure, and PACG. And the results were that older patients and eyes with higher baseline intraocular pressure were more likely to reach endpoint, and the number needed to treat to prevent an endpoint was 22. And the conclusion was, LPI treated eyes reached significantly lower endpoint compared to the controls. However, the overall incidence of PAC and PACG was low. So definitely you need not treat all PACS patients. So now the question is when to do LPI in primary angle closure suspects. The indications include, one is the need for frequent dilated fundus examination. This is quite significant in our scenario where we have a large diabetic population. Then in one-eyed individuals and in patients with symptoms concerning to intermittent angle closure and those living in remote area with poor access to healthcare, those with strong family history of primary angle closure glaucoma, and those patients who are on antidepressants or drugs with anticholinergic action. This has been termed as the PACS plus group. Now, another scenario is when the patient comes with a cataract and a shallow AC, what has to be done? You have two options. One is do a YARC-PI, do a dilated fundus examination, and then proceed with cataract surgery. Or straight away, you can go in for cataract surgery, but dilate the patient only in the operating room after giving IV mannitol. I prefer to go the first route because technically a YARC-PI makes the surgery more easier, and also a dilated fundus examination helps you to rule out any coexisting fundus pathology, especially if the patient is going in for any premium IOLs. So coming to the less common indication, then plateau iris, it is caused by an anteriorly positioned ciliary body. Laser iridotomy must be the first choice of treatment. Thereafter only you consider iridoplasty, topical pilocarpine, and the rest of the treatments. Then in acute angle closure glaucoma, definitely you have to do a laser iridotomy, but it may not be possible on the first day because you have an edematous cornea. So initially treat the patient with IV mannitol, oral acetazolamide, topical anti-glaucoma medications and steroids. And once the cornea clears, you have to do a laser iridotomy. Avoid extreme periphery because the AC is very shallow and you are likely to get corneal burns. Give post-laser steroids, and always treat the contralateral eye because around 50% of the patients suffer a second attack in the fellow eye over a 5-year period. Now, in phacomorphic glaucoma, it is the intumescent lens which is the culprit that causes angle closure. Lens removal is the definitive management. PI can be a temporary measure, but always be careful. Any accidental shot onto the anterior lens capsule will result in a phacolytic glaucoma. In uveitic angle closures, when there is extensive posterior synechia, there can be iris bombay and angle closure. PI is the definitive management. Do the PI on the most convex area of the iris. Since there is active inflammation, there is a chance that your PI can get closed. So do multiple PIs post-laser, cover with topical steroids and mydriatic cycloplegics. Then in secondary angle closures with pupillary block due to subluxated lens, laser iridotomy can relieve the pupillary block. You suspect a subluxated lens when you have a disparity in AC depth between two eyes, either from your clinical examination or from the biometry. When you compare the biometry of the two eyes, when there is an AC depth disparity, suspect a subluxated lens. A laser iridotomy can be done. In a dislocated lens in the anterior chamber, it can cause a pupillary block. Laser iridotomy is a temporary measure, but the definitive management is the lens removal. In malignant glaucoma, always do a laser iridotomy. First, eliminate any coexisting pupillary block, then only you think of malignant glaucoma and the further management. So to conclude, PAC and PACG are definitive indications for laser iridotomy. You need not treat all PACS patients. Consider patient risk factors before deciding on laser PI in PACS patients. And whenever you decide to observe a PACS patient, please do warn of the symptoms of acute angle closure. Thank you.
Thank you, Dr. Lita. That was indications for YARC-PI clearly explained. Next session will be by Dr. Manoj Pradhaban. He will be discussing on glaucoma surgeries, the decision making.
A very good morning to one and all. At the outset, I thank Dr. Roshni for giving me this opportunity. I'll be talking on surgical decision making in glaucoma. There are some judgmental errors that we commonly make, and we have to keep this in mind before making decisions on glaucoma management. There could be disease-centric and patient-centric. So some of the disease-centric errors are, was it a missed angle closure? Are we doing an unnecessary trabeculectomy in a patient who could just be treated by a laser peripheral iridotomy? Was there a component of steroid response, and wasn't steroid enough for treating this patient? Was the progression identified a true disease progression or just an artifact in our test? Is the field defect progression a fresh onset of neurological visual field defect rather than a glaucoma progression. Keep these in mind. When it comes to patient-centric errors, find out what is the expectation from the patient. Sometimes patient may push forward for a surgery because they may think that doing a surgery is to reverse the vision loss. Also, understand the patient's economical status, the ability to follow up, the adherence and compliance of the patient, and patient's understanding of the disease and the need for continued management. Keep this in mind before making decisions for glaucoma. And this slide is straightforward. The common indication for surgery, medically uncontrolled glaucoma, progression of glaucoma in spite of adequate IOP control, intolerance to anti-glaucoma medication, or as an add-on procedure sometimes to phacosurgery. Let us go over some of the decision makings with case-based examples and literature reviews. This is a 55-year-old newly diagnosed mild to moderate glaucoma patient with 28 millimeters of mercury. What is the treatment advice? So, a treatment naive patient, first time diagnosis, what should we do? Is it a trap or medication? All of us would agree that we start with the anti-glaucoma medication. So, we have the CIGIT study, collaborative initial glaucoma treatment study. The aim was to determine whether with newly diagnosed open-angle glaucoma patients, they fared better with anti-glaucoma medications or trabeculectomy. It was a multicentric randomized control trial, and the recruitment happened during 93 to 97. About 607 patients were enrolled, and they were randomized to anti-glaucoma medications and trabeculectomy. The mean intraocular pressure after 5 years in the trap group was 14 to 15, and in the glaucoma medication group was 17 to 18 millimeters of mercury. The IOP reduced from baseline in trap by 46% and medication group by 38%. The results showed that the visual score was same in both the eyes. So there was no difference. One was not superior to the other. But the visual acuity loss was greater in the surgery group initially, that is the first 3 years, because of lenticular opacities that were developing. And once that was dealt with, they were similar. So the recommendation was there is no data to support altering the current treatment approach, which is medication. But mind you that they also gave another factor. The IOP fluctuation was a risk factor for progression in the initial medical therapy group. So keep that in mind when you follow up these patients on anti-glaucoma medications. Next case is a 55-year-old male with advanced POAG with intraocular pressure 21 on maximum AGMs. What is the next step? Since the IOP is 21 in the normal range, should we continue with the same medications or do a surgical intervention? So mind you, this patient is relatively young, 55 years, another 25 to 30 years ahead. Advanced disease, so there is no tolerance for progression. So we have the advanced glaucoma intervention study. The recruitment period was from 1988 to 92. There were several reports that came in and over 700 eyes were studied. They tried to compare two treatment algorithms. So that is not really relevant now because we don't usually do ALT anymore. But at age 7 report, they did this associative analysis of 6-year follow-up. They looked at percentage of visits with IOP less than 80 millimeters of mercury. The Shall we continue? Okay. So these patients were categorized into 4 categories. So those who had percentage of visits with IOP less than 18 as 100%, 75 to 100%, 50 to 75%, and less than 50%. What they found was if the IOP was constantly throughout the visits, 100% of time less than 18, they did not progress. But mind you, in that particular group, their average intraocular pressure was 12.8. And eyes which had 50% of times IOP more than 18, they did progress. So the lower the IOP, it is the better. So that is why we have this concept of target intraocular pressure. Being in the normal ranges is not enough. So this particular patient who cannot progress, who should not progress, with 21 pressures, we need to surgically intervene to reduce the pressures to target range. So target IOP is determined by the age of the patient, the initial intraocular pressure, the stage of the disease, the risk factors for progression, and other eye status. Next case. A 65-year-old male with unilateral neovascular glaucoma secondary to proliferative diabetic retinopathy and vitreous hemorrhage post-pars plana vitrectomy with post-anti-VEGF injection Intraocular pressure 60. What is the surgery of choice next? Is it a tube or a trab? So we have the tube versus trab trial. About 212 patients were randomized into trabeculectomy and a barbell group. The inclusion criteria included patients who had prior cataract extraction or trab, and 81% of this population were having POAG. The 5-year results of TVT showed that both tube and trab did well over 5 years with IOP less than 50 millimeters of mercury. Trab group had higher failure rates. The take-home message: trab more likely to fail at 5 years. Trab had greater chance of reoperation and hypertony. Tube shunt has lower risk of serious complications. Trab achieved lower intraocular pressure with similar anti-glaucoma medication usage. Trab failure was higher, probably due to higher percent of patients who had prior failed trabs, so 55% in the group. So the results were skewed against trab. So this particular patient who had prior ocular surgeries with neovascular glaucoma, tube would be the right way to go. Next case, 60-year-old male with POAG on maximum anti-glaucoma medication with intraocular pressure 18 with progressive advanced disease. What is the best choice? Is it a tube or a trab? So here we have the primary tube versus trabeculectomy trial, or PTVT. They had 242 patients randomized to trab and barbelled. The inclusion criteria included the patients should not have undergone a prior ocular surgery, and 90% of the patients were POAG. The 3-year results of PTVT showed that both groups lowered intraocular pressure less than 15. The tube group had higher risk of failure. So the take-home points were at 3 years of tube surgeries have greater risk of failure, higher IOP, higher rate of reoperations, and greater need for medications. Tube shunt performed poorly at lower starting intraocular pressure. So coming back to our case, this particular patient who was conjunctiva, good conjunctiva, primary surgery, the best choice or gold standard is currently trabeculectomy. Next case is 65-year-old male with unilateral neovascular glaucoma. We discussed this patient earlier, and we found that tube is the way to go and not trab. So out of the tubes, which is the best choice? We have the Ahmed-Barwell comparison, or ABC study. The aim was to compare the efficacy of Ahmed versus Barwell in treatment of patients with previous intraocular surgeries and IOP more than 80 millimeters or refractory glaucomas. It was a multicentric randomized control trial. 276 patients were enrolled in the study. Patients in AGV group had lower intraocular pressure in the initial few weeks as compared to Barwell, which was expected. Patients in the Barwell group had lower IOP compared to AGV group after 1 month. This is because in the initial period we ligate the tube in Barwell to prevent immediate hypertony. Patients with Barwell glaucoma implant group required less topical ocular medications as compared to AGV at 3 years. So the failure rates were almost similar, and serious complications were also similar in both the groups. Next, we have an ABV study, Ahmed versus Barwell study. This was a very similar study to the earlier study, and the results were also pretty similar. The pooled data from both the groups, when we analyze, about 50% of them had POAG, 29% had NVG, and 9% had UAT glaucoma, and 7% had PACG. Barwell achieved lower intraocular pressures, 5-year control good in both the groups, and 0.5 medicines less in Barwell group. So the take-home message was Barwell implant had better success, lower IOP, lower anti-glaucoma medication, but higher hypertony. In NVG, Barwell had higher proportion of patients with PL minus vision. This probably is because NVG being a very aggressive disease, the initial time period where the pressures are very high may be the reason, or maybe because when the tube opens, there is an immediate hypertony that happens, which takes a few days to recover. This could be the reason why there is a poorer visual outcome in those patients. So in our particular patient who is having NVG with PDR, post-surgery PPV, the better choice could be Ahmed. It is slightly more safer than Barwell, but we can still go for Barwell with supramed suture in situ during surgery. Thank you.
Thank you, Dr. Manoj. That was an engaging session with those case discussions. Let me invite Dr. Ronnie George for the session on normal tension glaucoma. Sir will be discussing on diagnosis, management, and diagnosis, investigations, and management of normal tension glaucoma.
So good morning, and thanks, Dr. Roshni, for making me part of this. So I'm just going to speak to you shortly about the collaborative normal tension glaucoma study. This has been alluded to before also. So essentially, they took 140 patients who were considered to have progressive NTG, and they divided them into treatment or follow-up. And they had at least 10 intraocular pressure readings on these patients, and none of them, there was not even one reading more than 24, and at least 50% of the readings were less than 20 in each patient. And what they found was, compared to 20% intraocular pressure reduction versus follow-up, definitely the people who were treated had lower rates of progression. And at 5 years, 80% of the controls were stable as opposed to 40% of patients who were not treated. So what this tells you is that treatment definitely helped, but it also tells you that 60% of untreated NTG did not progress over 5 years. So a lot of the NTG that we see need not necessarily be progressive glaucoma, and that's the reason I think she put this topic. So there are a few concerns with the NTG, and the main concern here is there was highly variable progression in the untreated group. So you had two lots. You had one group which progressed very rapidly, and you had one group which did not progress at all. And it's important for us to be able to distinguish these two and to look at some of the factors which we need to consider. So why don't we treat all? I just told you why we don't treat all, because not everybody progresses. And keep in mind that NTG is very often a diagnosis of exclusion, and what you need to exclude is the confounders and the differential diagnosis that can happen with NTG. So the most important thing when it comes to a diagnosis of exclusion is a careful history and a careful clinical examination. And a few investigations which you can do if you don't find anything on the history on exam. So I'll share with you this 23-year-old lady. She's actually one of my optometrists. And they were fiddling around with a new machine, and they took a picture. And this is what her vision was and her intraocular pressure was. And you can see there's a nerve fiber layer defect there. And it's more clearly visible here. You can see there too. Her office diurnal was okay, Pachy was all right. But when you ask the history, turns out that she had mitral valve prolapse. And her blood pressure before she was started on treatment was 100/70. She was started on a beta blocker, and her blood pressure was dropping to 30 and 40. And she was having fainting episodes. So what she's had is a small disc infarct with an associated nerve fiber layer defect. So a lot of the confounders that you see in NTG is because of optic disc hypoperfusion. And why does this happen? This happens because if you look at the mean ocular pulse pressure, it's 2/3 into the mean arterial pressure minus intraocular pressure. And anything which causes a decrease in the blood pressure can reduce your ocular pulse pressure. And there is enough evidence that this is a problem because of two reasons. One, your intraocular pressure increases when you sleep, and your blood pressure drops when you sleep. So this combination can reduce perfusion quite significantly. In fact, 10 to 20% of blood pressure drop at night is common among normals and in most hypertensives. These are called physiologic dippers. When you look at nocturnal blood pressure and glaucoma progression, and you look at these patients who had a 24-hour ambulatory blood pressure monitoring and looking at visual field progression over 7.5 years, what you find is that among people who dip, almost 50% progress as compared to maybe 1/3 of patients or 1/4 of patients among the non-dippers. In another study which looked at the effect of nocturnal blood pressure reduction on circadian fluctuation on mean ocular perfusion pressure, they divided them into non-dippers, dippers, and over-dippers. Over-dippers are the ones with the black bars. And what you can see here is the over-dippers are the ones who had the worst mean deviations over time. So these are the patients who are crashing, whose blood pressures are crashing at night. And you'll be surprised if you ask for a 24-hour ambulatory blood pressure, you'll sometimes see recordings of 30 and 40, 1 o'clock, 2 o'clock in the morning, sometimes with even reduced cardiac rates at that time. The other thing in the history that you need to ask is whether they have had any history of steroid use in the past. And this is something which is rampant in our country. And you'll find people who have been using steroids for 3 years back, for 3 years continuously, and then stopped it. And now you're seeing damage and you attributed that to NTG. So if you have any history of systemic disease where you suspect hypotension could be an issue, consider 24-hour ambulatory measurements. Also take a history of significant blood loss. A traumatic pregnancy can sometimes be a reason for a disc infarct if they've had massive blood loss at that time. The other thing that you need to keep in mind is sleep apnea. And if they have any history which is suggestive of sleep disorders, it's worth investigating. And keep in mind that not everybody has a short, thick neck and is obese. You can get sleep apnea in people who look slim and absolutely healthy too. What about the non-blood pressure cause of hyperperfusion? And here among them, like I said, it's sleep apnea, because hyperperfusion is not an issue here. What is happening over here is reduced oxygenation to the optic nerve because of reduced oxygen uptake at night. I'm not going to talk too much about this except to show you this meta-analysis on sleep apnea. This is of all the studies put together. In NTG, you found that people with sleep apnea had a 3 times greater risk of having NTG. So studies have fairly clearly shown that sleep apnea is a risk if you have a history, if you have unexplained progression, or if you have somebody where you are eliciting, you're not comfortable of the way the disease is behaving, it's worth considering a sleep study. This is the other thing that we sometimes look at, the other reason for hyperperfusion, and that is because of vessel occlusion. So the carotid Doppler is one way of screening for it. Unfortunately, what happens is when you do a carotid Doppler and you see a block of, let's say, 10 to 50%, and you send it to the to your interventional cardiologist or whoever, they are not interested. They say this is nothing. Less than 70-80%, they're not even bothered. But when we looked at our own data of all the patients that we sent for evaluation, you find that among the normal tension glaucoma group, about 11% of patients had a block of more than 10%. While we look at glaucoma suspects, there's only 1% who had that. The population prevalence of any degree of occlusion on the carotid Doppler is about 3 to 5%. So in glaucoma, you're seeing almost double that. See, what we are seeing here is much more distal to what is going on close to the optic nerve circulation. So we don't know. So this may be just a symbol of sign for them, for us to encourage them to put them on anti-cholesterol medications or whatever else, but it's something that we need to keep in mind. The next issue is it really normal tension glaucoma? And this is a problem with intraocular pressure. So if you look at IOP, this is a study that we did using 7 different instruments to measure intraocular pressure in each person. And these graphs show you what is the difference in intraocular pressure that we recorded with the appellation tonometry versus each of those instruments. And you can see how variable they are. You're getting a difference, at a pressure of about 14 years, getting a range of plus minus 6, plus 4 to minus 6, depending on what instrument you use. So if you're seriously looking at NTG, make sure that all the intraocular pressure measurements are with a Goldman appellation tonometry and not with an NCT or anything else. Get enough measurements, but keep in mind that our measurement variability itself is significant. The second issue is we are looking at patients during office hours most of the time. And if you look at this study, you find that most of the time, a good proportion of time, about 30 to 40% of time, the peak intraocular pressure occurs outside of office hours. So somebody with 18, 19 who you think is NTG may be going up to 30 at night and you will not pick it up. Also keep in mind that if you're getting intermittent intraocular pressure spikes, like if you do Shirshasana or if you're doing any type of Valsalva maneuver, that can be one of the reasons for intermittent intraocular pressure spikes which are causing progression. So this is a young gentleman whom we saw, a young glaucoma suspect, family history of POAG, vitamin B12 deficiency. His intraocular pressures were like this, and you can see those inferior nerve fiber layer defects there, bilateral nerve fiber layer defects here. This is his right eye. Visual field staying absolutely stable over almost 10 years. OCT is also more or less stable over 10 years. Showing a little something in the macula at that point. This is the left eye, and you can see he's got much more well-pronounced biaquate nerve fiber layer defects. Yeah, I think, no, this was 10 minutes. yeah. So this is, he had these sort of superior defects and some few scattered inferior defects over there. And what you're happening there, that's his macula, which is showing worsening. And that's his GPA on the NFL, which is not showing too much. But now you look at all his intraocular pressure readings, and you're seeing that he started to spike 22, 24, 26 with time. So this is somebody who we thought was basically NTG's part of the spectrum, while he's actually the POG part of the spectrum. And a few years down the line, about 3-4 years back, his father came to me, and his father is a classic ocular hypertensive with pressures of 28 and 30, but no defects. So this man, we got confused because he was young, not really a POG, not really NTG profile. He was a very strict vegetarian, very low vitamin B12 levels. So B12 levels can sometimes also cause these field effects. Of course, he stayed stable for years, but now we are being a little bit more aggressive with therapy. The other thing that you need to remember is that very rarely young patients with NTG, progressive disease, can be because of a genetic mutation. So OPTN or TBK1 mutations can sometimes present with progressive disease. You can test for OPTN. TBK1 is a little difficult to test for. So but this is rare. It is like 1 to 3% of NTG. NTG fortunately is not very common in the country. So I am yet to see more than 1 or 2 patients with OPTN1 mutations. But it's something that you just need to keep in mind. And this is a family which has been the first family that was reported by John Fingert and others, where they had this, pretty strong progression in the family. I'll also share with you this slide. This is something which is looking at so what you're looking at, these are the genetic loci that code for intraocular pressure. And you're trying to see which are the loci which are associated with primary open-angle glaucoma. And when you compare the loci for POAG with the loci for NTG, you see that it's almost the same. So keep in mind that most NTG is part of the POAG spectrum. Our job is to identify the ones which are those low eye pressures which are progressing in spite of everything, or the ones where there are systemic and other risk factors which might help. So generally lowering intraocular pressure helps to slow progression in most patients, and the treatment of choice is the prostaglandin followed by surgery. But you can have different susceptibilities to intraocular pressure. So some of these patients are very, very IOP susceptible. Keep in mind ocular blood flow and see what you can do about that. Investigate them if required. The other confounders, the ones that we worry about, are basically these. The ones who are showing vision loss, the ones where some clinical findings are not matching what you're doing. So here you're seeing a disc which doesn't really look glaucomatous. It's a large disc, large cup, but there is some temporal pallor. And this patient was treated for glaucoma for 5 years with normal pressures. You do a field and you see a classic midline defect, and he's got a pituitary adenoma. This is not uncommon. We see it all the time. So if you see anybody with vision loss is not typical of glaucoma. If you see somebody with pallor in excess of cupping, and if you see any defect which is even few points which are close to midline, nothing else going on, investigate them. It's well worth it. Even if your false negative rate is high, please go ahead and investigate them, because we can't afford to miss these. And I'll finish by showing you this slide again. So this is that lady who had mitral valve prolapse. This is what she looks like now in the right eye. This is what the left eye looked like at that time. This is what the left eye looks like now. You can see that superior defect. You can see that on the OCTA and on NFL imaging. The mean deviation looks absolutely stable, but you look at the visual fields. She's got a superior arcuate in one eye and an inferior arcuate in the other eye. And this is the 10-2, which is showing defects close to fixation. I didn't treat her. I was following up in between, and you can make out that both of us took it easy, and she also didn't come for her checkups. NFL defects. Intraocular pressures. This is 17, 18. You are starting to see a couple of peaks. And that's the other eye. So I suspected NTG, started her on vimetoprost. After that, she's been stable. So why did she progress? Was it a missed NTG to start with, or did the vascular insult increase the optic nerve head susceptibility? We don't know. But we achieved an almost 40% reduction with intraocular, with the prostaglandin, and she's doing well after that. So the question here becomes that you need to take a detailed history. Keep in mind that most NTG is pressure sensitive, and progressing NTG in spite of a good intraocular pressure control is somebody who needs further assessment, and have a high index of suspicion in non-typical cases. But even the ones where you're convinced it's not NTG, keep them on follow-up, because sometimes they'll surprise you. Thank you.
Thank you, sir. That was NTG well explained, the confounders, the need for treatment, everything. Now we are open for discussion. Any queries we can answer any queries. Sir, I have a query. Many patients ask me whether they can continue their yoga, or as you mentioned about Shirshasana, which are the safer yoga practices?
Well, actually speaking, Shirshasana definitely you need to avoid. Any asana where the position of the head is down has been shown. There are papers now that have shown that any asana where the position of the head is dependent for time should be avoided. We have a current study going on which shows that even with Kapalbhati yoga, where they do that rapid breathing, your intraocular pressures go up and perfusion comes down. So somebody who's progressing despite everything, definitely avoid.
So then in NTJs, do you advise the patients to sleep without pillows or anything like that to improve the blood flow, something like that? Does that have a role?
Yeah, I think, no, I mean, I don't do that because I would be miserable without a pillow. I'm sure they would be miserable too. But I think part of your question comes from the studies out of Korea, which have looked at which side you sleep. And they find that the side that you sleep on has worse optic disc damage than the side that you don't sleep on because of the pressure that you put there. I don't really do that because it's a big lifestyle change for patients.
So despite treatment, if the NTJs progress, do you
despite treatment, if the NTJs progress, I definitely consider doing an ambulatory blood pressure, especially if they're on antihypertensives. I get rid of the night dose of antihypertensives if I can. I look for sleep apnea. And again, it's always important to ask for compliance because sometimes that is the reason patients don't progress. But somebody who's close to fixation and all these are negative, I discuss with them and I say, maybe we just image you also. But if everything is negative, you just have to get aggressive with treatment and consider surgery. Because don't forget that even if you are getting a pressure of 10 or 11 with a prostaglandin, and you're getting the same pressure with surgery, your fluctuations come down. So that helps.
Thank you, sir.
Is carotid Doppler mandatory in all NTJ cases?
So, okay, if you see a pressure of 18, 19, and you see a disc with a superior aquate type of defect, I would not be too concerned. But if that patient is progressing in spite of you bringing the pressures down to 12 and the defects are close to fixation, I would consider doing it. See, it's a non-invasive test. It's not very expensive. And if you see something that lady didn't have NTG, but I had an elderly lady who was coming to me and 3 visits in a row, 2-3 months apart, she's showing a disc hemorrhage. Pressures are okay, fields are going like this. I got the carotids done. She's got a 90% block on both sides. She underwent an emergency endarterectomy and she came to me saying, after 6 months, saying, thank you, you saved my life. So that's the odd few patients you'll see, but yeah.
Sir,
Sleep apnea study in normal.
So not in all NTGs. If, like I said, most NTGs are run-of-the-mill POAG. But anybody where you're suspicious, anybody who gives a history of daytime sleepiness or the wife tells you that he snores like mad, get a sleep study done because it improves quality of life a lot. Even if it may not improve your NTG, if they treat sleep apnea, people are much happier.
Sir, you said ambulatory BP monitoring, so you send them to a hospital?
Yeah, so typically it's always better to have some sort of speak to some cardiologist who will listen to you. And you will find somebody, and they don't mind doing it because for them it's easy. And it's sometimes difficult to convince them that hypotension is important. So you can do something about it if the patient is on antihypertensives. If the patient is not on antihypertensives, then it's just increase salt, increase water. You can't do much else.
One more thing, sir. Sir, you said neuroimaging. We have to do an MRI, brain and orbit, or anything specific?
MRI, brain and orbit, make sure there are enough slices of the optic nerve. Because sometimes if you just send it for screening, they'll take 5 millimeter slices. You will not get something which is just in the canal.
Okay. Thank you, sir.
Glaucoma patient on medication after surgery, can we continue on day 1 prostaglandin?
So when the prostaglandins came in, I was not stopping it. I was just continuing it post-op. Day 1. Now I don't. Because whatever you say, you'll land up with maybe a little higher CME than otherwise. So what I tend to do is I stop it from the day of surgery. I keep them on a topical non-steroidal also for 5 to 6 weeks. And 2 to 3 months post-op, I switch them back to the prostaglandin. In between, I put them on a beta blocker or whatever else is safe for them. It's always, even if you get 5 patients with CME out of 100, those are 5 patients who are unhappy and who have to come back to you again. So it's better to just switch. Even with advanced glaucoma, because very often cataract surgery will give you the benefit of slightly lower pressures for a little time. And you switch them to something else, wait for 3 weeks, and if they're on more than 2 to 3 drugs, it's better to do a combined procedure rather than a cataract.
So now we have come to the end of the session. Now I would like to invite Dr. David Pudukkar to hand over a memento of appreciation from KSOS to Dr. Roni George.